So I have my traveling mic because I'm one of those electro-walkers. And let me see, I will try to remember, and I'm going to look at Chris because he was doing this to his wife, like, advance a slide, advance a slide. So we're all like trying to advance our own slides up here and we forget about these because we're not looking there, we're looking at you. So just a few disclaimers before we get started. Oopsie, not too far. I have been the principal investigator for a clinical trial involving fascial counterstrain for post-traumatic stress symptoms. I'm also the head of impact for the nonprofit organization, the Bridgeback Project, which I co-founded in 2017. And I am an instructor for the two educational institutes in the United States, the only two that teach fascial counterstrain. There are no medical schools in the entire world that teach fascial counterstrain, only continuing education schools. Unfortunately, that would be nice to change at some point, which is why I'm here. I want more of you to learn this. And there are schools, and we'll show you at the end, but there are schools. There's a school here, Kiné Formation, in France, or not here, but in France, and there's also one in Australia. So why do we even care about fascia in the first place? Because everybody in this room learned in school that it's an inert substance that can be cut and ripped off, and nobody even cares. Who cares about that stupid stuff that just holds things together? It does a lot more than you think it does. It is highly innervated with type 3 and type 4 neurons. Highly innervated, more than any other structure in the body with these type 3 and type 4 neurons. They are protected, so its job is to sense danger. It is actually the biggest organ in your body. It goes everywhere. It goes over your brain and your spinal cord, every single nerve, every single vessel, every single organ, every single bone. Oops, see, there, I forgot to advance. So this is what we do care about fascia, because without it, we wouldn't have any protection in our body. Also, fascia is contiguous throughout the body, meaning if you have, everyone knows this one, if you have muscle, tendon, and then it goes into the bone, the fascia around the muscle becomes contiguous with the fascia around the bone. Guess what? An artery, the tunica adventitia, or the outer layer of the artery, or the epineurium, the outer layer of the nerve, becomes contiguous with whatever structure it goes into. That'd be a muscle, an organ, whatever. Even the spinal cord, which is marbled in vascular tissue, all of it is contiguous, meaning everything is connected. What do we start out as? We start out as a single cell, another cell comes in, and it just divides multiple times. So everything really is connected. It's not just woo-woo. It really is actually physically true, and I am the physical medicine queen, so we're about to learn more about physical medicine. Been studying for many, many years. There's actually an International Fascia Congress. Who's heard of that? Oh good, there's a few people who've actually heard about that. That's great. There's actually an international meeting just on fascia and its impact in the body. Pretty cool, huh? It has impact in the autonomic nervous system and in every single tissue in your body. Kind of important. This is a quote from Robert Schleep, and then there's another one from Richard Van Buskirk. I'm happy to give you my slides later if you want to read. I'm not going to read them out loud for you. But basically what we're saying is fascia does contract. It is highly innervated. Its job is to protect. And we have nociceptive input that causes the fascia to contract so that it will protect you. Once it contracts, it then traps chemicals, inflammatory chemicals like cytokines, IL-6, NF-kappa beta, interleukin-1 beta, etc. There are many that have been studied. If you take the fluid out of a trigger point, you will find these cytokines. They then deactivate the local lymphatic pump. They initiate fibrosis, and then we have tissue change. We also have lack of perfusion. Not good, folks. So, how does dysfunction occur in the body? We have some kind of threat to the body, which then excites the local nociceptors, and then we have limited perfusion, and then we have reflexes in the somatosympathetic reflexes, we have viscerosympathetic reflexes, we have loss of perfusion, loss of range of motion, the lymphatic pump then gets squeezed, so it's like driving a truck over the irrigation system to an orchard. You don't get flow in of good clean water, you also don't get flow out of waste. What's going to happen to the apples on that tree? They are not going to thrive, right? There's going to be no protection against the bugs that come in. They're going to rot and fall off, or they're not even going to grow. So that's what happens to an area that has interstitial inflammatory stasis. Who here was here last year and heard me talk about interstitial inflammatory stasis? So interstitial inflammatory stasis was a term coined by the innovator of fascial counterstrain, Brian Tuckey. You won't hear about it anywhere else but in his article that was published in 2019, and it's read more than 99% of all other articles in the history of frontiers, if you read any frontiers articles on PubMed. So kind of an important, very popular document. It's all about the theory of why counterstrain even works in the first place. What does interstitial inflammatory stasis result in? Lack of range of motion, pain, guarding, and idiopathic visceral and vascular disorders. So I'm going to summarize those three main elements. We have these things that initiate dysfunction, which are basically threats to the system. Trauma is a threat. It can be trauma that is, you are a firefighter and you scoop up dead people off of the pavement. You can be somebody who's almost died in a car accident. You could have been abused as a child, and any other form of mental, physical, or emotional trauma, which a lot of people have talked about today. And we know what that does to the sympathetic and the parasympathetic nervous system. Okay? It can also be just a physical injury. You don't have to have trauma that is mental, emotional, associated with a physical trauma. Surgery, infection, disease, all of that causes these inflammatory responses, results in nociceptive stimulation. That physical compression traps the inflammation, does not allow inflammation to drain out, because those cytokines have been studied to actually stop the lymphatic pump mechanism. Everybody in this room knows about tender points, right? Or myofascial trigger points. Yep. And we've done all these things to them. We've stabbed them. We have ultrasounded them. We have EMF'd them. We have forced them in multiple ways to move out. And guess what? Who has had those come back? Really? Not very many of you have those come back. Okay. Well, they often come back for my patients if I don't do counterstrain. And when they go away, it's because we're doing the thing that they need to drain out. Meaning we're going in the direction of ease on accident, unless we're doing it on purpose with counterstrain. There isn't another physical medicine modality on the planet that I know of, with the exception perhaps of craniosacral therapy, which does go with the balance of the body. This is the only one that I know of that in every single tissue in the body goes in the direction of ease. We're not forcing anything. When we go in the direction of ease, we are opening up these lymphatic channels and allowing for the inflammatory chemicals to drain out. That makes sense, doesn't it? When we do scar therapy, most people who do scar therapy, again, are injecting it, stabbing it, ripping it apart so it can reform, and hopefully this time it'll lay down better. Well, what if we instead thought about it like a tree with these little roots of scar tissue going down into the body, and we follow each root in the direction of ease? Then it's going to stay gone. And it also attaches to a specific structure, which we can find with the diagnostics in fascial counterstrain. So we're here today in this lecture to talk about visceral pain. So visceral pain is a visceral structure that has been threatened, and then the shrink wrap happens in the fascia. Then we have trapped inflammation, and then we have these trigger points that form that are specific to an organ, a ligament of an organ, or a sphincter, or a piece of mesentery. The visceral pain, we can't say, you know what, my pancreas hurts, or I am having a heart attack. Why do we send people to the hospital with a heart attack? Because it could be many different things, right? We can't say, oh, my left anterior descending artery is in spasm, or is blocked, or it had an infarct. We can't say that. But we can say we have pain. And most people who have visceral complaints will come in with pain complaints, because they don't know that it's an organ and how it's attached to the scaffolding of your skeleton. Oops, you're supposed to be looking at that like I am. So again, when inflamed or traumatized, an organ and its tunics will contract. That contraction will cause loss of range of motion. It will also cause trigger points. It will cause multi-segmental dysfunction, and it will cause loss of perfusion to and drainage from an area. Enteric nervous system is a system that is completely independent of the CNS. You can cut the vagus nerve, cut the sympathetics, and you will still have a functioning digestion. So if we just treat the sympathetic and the parasympathetic nervous system, which we can do with counterstrain, and I'll talk a little bit more about tomorrow, we will still have to treat locally, because we still have a lot of inflammatory cytokines in the mesentery, because the mesentery is what connects all of your organs to the back wall of your body from your pharynx to your anus. It's not just your small intestine, which is how I learned it. That's the mesentery. Nope, it's everywhere. It's what connects the back of your heart and the back of your lungs, your esophagus, even your carotid sheath is considered mesentery now. Look it up. It's actually looked at as a new organ. Okay? Even the fascia of Tolt is considered, and the ligament of Treves, the triangular ligament of the liver, all of these things are actually considered mesentery now. Mesentery now also is rich in stem cells, can produce CRP. Another really often ordered test, right? Who orders CRPs on their patients? If you have a high CRP and that patient eats better than you do, or you're throwing your hands up in the air, well, I can't find anything wrong, you might have somebody who has visceral dysfunction. And we can fix that with just these and this brain that's inside your head. Okay? Once you learn this stuff, all you need is your hands, and you can fix things. So we have these major issues with systemic inflammation that can be due to a simple dysfunction in the fascia that you can fix without a supplement, without a diet, without any other changes. Do all those things need to happen too? Yes. If your patient is obviously dysfunctional in their diet and their habits, those need to change as well. But what a great adjuvant to this. Okay, we can use our hands. It's extremely naturopathic, isn't it? Find the cause of disease and fix it. Use the body to heal. Use as little intervention as you need. Just push on the lung, and the neck pain goes away. What? How cool is that? Who wants to learn how to do that? If I could plug this into every single person in the room, medicine would change overnight. Unfortunately, it takes a while to learn all of that. Causes. There are many causes of visceral dysfunction. Okay? I'm not going to read them all, but the two on the bottom are the ones that you probably haven't heard of. These have all been up with other people, except for maybe sacral unleveling, leg discrepancies. If your body's out of balance, like if I have 1 foot off the stage and I'm walking around like this, do you think that's going to affect how my organs are sitting in my body? Absolutely. So, unless you've taken a counterstrain class at the highest level, you've never heard of neural crest sensitization. What that means is your cranial bones and the cartilage in your head have an impact in your body. So, for example, your temporomandibular joint can cause mesenteric dysfunction all down one side of your body. A simple change, a simple shift in your jaw, posterior inferior jaw transfer with monitoring of a tender point to feel the lymphatic pump mechanism returning, can completely change the mesentery on one side of your body. So there's neural crest sensitization as well. All the cranial bones, by the way, will cause, if they're in torsion or protection from a head injury or a fall or even the birth canal, will cause dysfunction in huge parts of the body, like all the posterior inferior nerves of your body, for example, or all the astrocytes from T7 and up, or all the astrocytes in your brain. Big deal. Medulla obviously houses your dorsal motor vagus. So do you think if you had dysfunction in the medulla that you might have a problem with your gut peristalsis? Yes, absolutely. So, in summary here, visceral dysfunction can be just masquerading as disease. It can look like disease that you can fix with physical manipulation. It causes multi-segmental restrictions because your lung, everybody breathe in as deeply as you can. Your lung is now above your clavicle all the way down to rib 11. That is a huge structure, and there are 2 of them. Just by itself, one would be the biggest organ in your body. You've got 2. How many people have treated somebody who's been in a car accident? Okay, a lot of people in the room. Okay. When you have a patient who's been in a car accident, we are doing acupuncture, we are doing massage, we are doing all sorts of physical medicine, we're doing hydrotherapy. All these things are great and they're really helpful, but we're treating the muscles, the tendons, and the bones, and the joints. If I have a giant strap across my lungs and I fold around it in a car accident, what else is being threatened? Anybody have an idea? I heard heart, yes. What else? Those 2 big things, your lungs. Who thinks when they have a car accident patient come in, I should check the lung attachments? Who says they should check? Who's thought that before? Right, I didn't either. I had no idea that my organs could be causing problems in my body. I was a professional athlete, I was a goalkeeper. And as a goalkeeper, you fly through the air and land, you fly through the air and land, you fly through the air and land. So you're talking thousands of whiplash injuries over time, right? So I had a completely stuck rib cage. I could barely move before I did counterstrain. Now I can move really well. I also had multiple head injuries, including double compound fracture of my septum, or of my nasal bone or my septum, and multiple loss of consciousness injuries. And I can stand up here and speak to you today because of counterstrain. God knows how smart I'd be if I hadn't been kicked in the head. So if we have a patient, and I do treat professional athletes still, there's a lot of professional athletes who use counterstrain, and lots of famous people that you probably know who use counterstrain, because once you find out about it, you want to get it. If you want to really understand this, have me do a tender point treatment on you, and I'd be happy to do that. So if I have a soccer player who says, I can't do a jumping header to the right anymore, I can only do it to the left, but I can't turn to the right. My left rotation's fine, my right rotation's limited. I'm thinking a large structure, like a lung, is causing the problem. And there is a very famous soccer player, who of course I can't name, who that was his exact problem, and he ended up getting an award for his soccer playing, and I can't tell you where or how, but he did, because he was able to do jumping headers again, in both directions, after visceral manipulation of his lungs. Not your Barral technique or your force-it techniques. This is going in the direction of ease, restored full range of motion of his ribcage. Very important for an athlete. Also important for somebody after experiencing COVID. Lots and lots of coughing threatens your lungs. The tunics tighten. You cannot expand your ribcage as well. Lots of different symptoms. Many of these, no one in this room has even thought would go with a visceral problem. For example, who thought thoracic outlet syndrome could be due to a visceral dysfunction? That's just a nerve, right? That's just your neck is out. Well, it could also be the Simpson's fascia or the cupula of your lung, which attaches at the C7, by the way. Did you know that your lungs attach to C7? Who knew that? Good. Somebody teaches anatomy and physiology in this room. Do you? Yeah. Thought so. But the rest of us forgot that, because we didn't use it. I had to relearn anatomy and physiology 10 years into practice. I've been doing this for 14 years now, 24 years in practice. If I had to give up every single tool, and I'm also an acupuncturist, by the way, I would give up every single other tool but this if I had to give everything up but one. I'd keep this. It's more impactful than anything else I have in my tool bag, and I have a lot. So the answer is counterstrain. You can take a picture of that if you want. I'm not going to read it. Brian Tuckey is a brilliant genius who actually also has social skills. He's a good friend of mine, and I'm the second person that he asked in the entire world to teach counterstrain, so I'm very proud of that fact. This man is very generous with his information, and he is the one who wrote the article on interstitial inflammatory stasis. If you look up interstitial inflammatory stasis and Brian Tuckey, or you ask me for my slides and you can see it as a reference, you can read his article. So, treatment of the cardiopulmonary structures. This picture here is inside the lung looking up. Okay, so you can see that the lung is actually attached to your subclavian artery. It's attached to your brachial plexus. Okay, it's attached to the C7 vertebra. Your deep cervical fascia encases all of the viscera in your neck, including the carotid sheath, your pharynx, larynx, trachea, thyroid gland, etc. So we can have dysfunction in your thyroid because of a visceral problem as well. Or we can treat the arteries to the thyroid. The superior and inferior thyroid arteries are treatable. So we can treat those too. So here's a really quick case study here of a young woman I was at an event for Tony Robbins where he had us come in and do fascial counter. Who knows that guy? He's kind of a loon, isn't he? But he has some good things to say. But he had us come to one of his retreats on health and life and wealth mastery, offering counterstrain to the participants. And we had people lining up out the door. There was 4 of us in one hotel room with 4 massage tables treating people all day long. So we couldn't take a huge long history. This woman comes in, she just said, fix my neck pain. I'm like, all right. So I do some joint oscillation testing, and I scan. So we have a cranial scan where we tell which system is in dysfunction. Turned out she had viscera. Didn't tell her that, just started working on her. And I'm, compressing around her pharynx and her lungs. And all of a sudden she goes, and her eyes get really big. And she's like, is it possible that you're also helping me with my breathing? And I said, well, as a matter of fact, I am. I'm working on the visceral attachment of your lungs. And she started to cry. Wow. And she said, I was born with my arm over my head going through the birth canal. And since I was born, I have never breathed through my left upper lobe, and I have never breathed through my left nostril. And she's like, she's breathing through the left nostril, she's inflating her left upper lobe. I started crying too. And we were both like, oh my gosh, this is absolutely miraculous. I never knew I could do that. That happens to me, by the way, still. This many years into doing this, I am still shocked by the things I can do, because there's so many things that counterstrain can do, nothing else can do. Like, Brian brought a guy's vision back. Navy SEAL who'd been blown up and couldn't see out of one eye, brought his vision back by treating the optic, ophthalmic artery and the optic nerve. I have brought a 95-year-old guy, had a hearing test before and then after I treated him, and it got better. Not supposed to get better in your 90s. So you can see how this stuff is exciting. I forgot to advance the slide again. But here you have this patient who could not breathe, didn't tell me she couldn't breathe through her upper lobe and her nostril, and then all of a sudden, boom. After literally 15 minutes of treatment, she's breathing through her upper lobe. So mesentery, who has heard of mesentery? We just talked about mesentery being from the pharynx to the anus, very important structure. It contains the vessels, it contains the nerves that supply all of your organs. If you drive a truck over those, do you think there's going to be a problem with the organ? Yeah. Do you think maybe that might also cause, if all the structures in the back of my body are tight, I might have kyphosis, I have limited extension, and I have pain, right? Yes, also, we can have all sorts of things with C-reactive protein, systemic inflammation, etc. But here's a very simple case of a 22-year-old, very healthy young man who gets in a mountain biking accident, and he immediately seeks treatment. He had back pain, lack of thoracolumbar range of motion. Those were his complaints. His only system of dysfunction was what was threatened at the bike crash when his bike handle impaled his abdomen. He had no problems at all with his muscles, his joints, anything. Even though he couldn't move them, and he had lack of side-to-side and extension, he had lack of forward bend. Treatment of just the mesentery restored full range of motion, and his pain was gone. What does that tell us? All of this stuff that we're treating as musculoskeletal might not be a purely musculoskeletal problem. Your muscles get hijacked by your autonomic nervous system to protect a structure. It's like putting popsicle sticks on a broken finger. Okay, so we can have a problem in the body that was causing pain, and the patient comes in complaining of pain. They might not even tell you they have IBD. If we hadn't treated this young man, might he have developed IBD or IBS, or constipation, or any number of different problems with his guts? Diverticulosis, absolutely. His mesentery was strangled. The mesentery is where we have lymph nodes, where we have vasculature, where we have nerves going into and out of our guts. So if that gets strangled because it's being protective, we have dysfunction. And then later we can develop disease. But guess what? We can reverse the disease process, we can reverse dysfunction, and we can clean things up just with using our hands. All of the other stuff is important. All of the stuff that's previously been talked about, yes, also important. And we also need to use our hands. We need to touch our patients. Okay, so I was going to, let's see, how much time do I have left?
7 minutes.
Oh, perfect. I have a case study. I'm going to skip just know that valves and sphincters are important. The end. There's references. But I have, what I wanted to get was a patient in the audience who has trouble breathing and also has neck pain, and I found somebody. So, Steve, are you here? Oh, you better be here, Steve. Oh, there we go. Okay, good. All right, so I would like everybody to be able to see this. So if you're in the back and you want to see a demonstration, please come up here. A little easier to see over here. You guys can come on over. So this is Steve. You might have seen him speak yesterday. And I was just asking him, I said, I want a demo, and I don't want to have to check everybody in the room because that'll take way more than 20 minutes. So what we're going to do is we're going to have Steve do a little bit of range of motion, and he's going to tell us if he has to do, so your main complaints are pain, right? So limited neck range of motion. Okay, so let's see your neck rotation. Other way. Lateral flexion. That sucks. Extension. Not terrible. Inflection. Good. And now let's put your arms like this, and then we're going to do a rotation. Okay? And the other way. Now, this is a really key one here. Put your arms at your sides, and then slide your hand down your leg. And then the other way. Okay, so I want you guys to watch something here. He's bending just right here. There's nothing happening here. So when I bend, you see my shoulder coming down, and my whole spine is doing this. Right? That's what I want to see him do, but he's doing this. Do you see that? Yeah. Do that again. Look at the difference between he and I. Big difference, huh? Okay. That shows me that he has some large component going on, some large structure problem. It doesn't have to be visceral, but we're doing a visceral lecture, so it can be, we're doing visceral. By the way, when we teach the counterstrain classes, we teach it by system. We first teach the foundations, which is class 1. Then we teach visceral and mesentery. Then we teach artery. Then we teach 2 lymphatic venous classes, etc. Nerve 1, nerve 2. There's 3 musculoskeletal classes. There's an adipose class, etc. Okay, so there's a lot of classes. Okay. Turning around. Now I'm going to do very quickly what I do in clinic, and that's just a motion test, a joint oscillation test. Okay. If I go, so what lives here and here? Central nervous system. That kind of rules the body, tells the body what to do. Information goes in and out of the spinal cord. So if I find the most restricted segment in his central nervous system, because it's attached to the nervous system, I will find where to start. If there are 2 segments that I'm not sure where to start with, I will do touch inhibition. Who does acupuncture in here? Okay, so you guys all know what touch inhibition is. 2 points. Which one do I use? The one that's still bad when I'm touching the other one. That's the most loaded point. Okay? So I'm just going to start all the way up here at the base of his C1. That's not terrible. You can see me moving as I come down. Right there, he starts to get really stuck. And there, stuck. Moves. Okay? Now it moves. Moves, stuck. All the way down to coccyx, he moves in his sacrum moves, all the way down to coccyx moves. So he's stuck in his lumbar region, and he's stuck from here to here. Okay? So then, I can go to his viscera and his mesentery, because those are the 2 scans. His mesentery is in his bad. The mastoid process, turn to your side, please. Mastoid process is an egg-shaped bone right behind your ear, slightly slanted. All the way around the periphery of that little egg is your visceral scan. Okay, everybody can feel your visceral scan? If you go from the outside toward the center of it, all the way around, this is going to be the lung structures, okay? And then the sphincters are going to be in the middle, and then down here is pelvic structures at the very base of the mastoid. He can tell you that's pretty nasty right down there. Also pretty nasty up here in the lung region, in the posterior aspect, but really bad in the anterior. Wouldn't you say, Steve? Is that worse than down here? Or about the same? About the same. Yeah. So I can touch inhibit. So if I touch his posterior pelvic viscera, and then I check the lung again, it's still tight. If I touch the lung, and I test the posterior viscera, that gets better, yeah? Okay, so his lung, superior, posterior lung is primary. So, you're much taller than I am, so I'm going to stand on this.
Right on. Like so.
All right, now I'm going to bend with you, so I want you to do that lateral flexion to the left again. Your whole body, remember? Slide your hand down. Has that changed? Okay, do the other way.
He's going further away.
So now he's getting that. Now he's getting more of this going on. All I've done is touch where his head says it's a problem. Do it again without me touching you. Gone back, okay, to just this. That's because I haven't treated it. I've just found this cranial scan, part of his temporal bone, relates to what the problem is. Okay, because I've partially fixed it just by touching what relates to his cranial scan. All right. Let's see, which I have you. Go sit. All right. So I know, because I teach this and I've done it for a long time, where his visceral tender points are on the superior aspect of his of his rib tubercles. If I also do this motion testing and I see this whole area locked, the worst area is up at his T1, T2, and even like C7.
Yeah.
Okay, and he'll tell you it's even tender in there. Do you remember how I showed you there was a slide? Don't move, I'm gonna hop over you.
Yeah, go ahead. That's fine.
Oops.
I won't move.
Yeah, no, that was one. Okay. C7, those green things, by the way, that's in German, I believe, is attached to the pleural dome of the lung. Do you see that?
Yeah.
Who knew that? Do you know when you see people with asthma breathing, they're using their neck muscles to breathe because they're trying to lift the lung up to expand it. We're sucking the air in that way, right? Okay. So, I will do one more thing here because we know the brachial plexus, which comes out right here, comes and is attached to the dome of the lung, is going to be affected by this. Okay? So, extend your wrist and your fingers. Okay, if we go right at 90 degrees, tell me when you start to feel a stretch down your arm.
There.
Right there. So we're not even at 90 here. Okay, we're at like 70, 80. Okay, we should be able to be 30 degrees behind him would be normal. Okay, so we do have a Simpson's fascia tender point here on the superior rib tubercle of the first rib. You feel that guy? Okay, pretty tender.
Yeah.
That's Simpson's fascia, and we're also going to go on the anterior surface of C7 in the front. Also not happy.
No.
So there's if you find, so your C7 sticks way more laterally than your C6. So if you go down to C6 and then you go out to C7, go behind your clavicle, but straight back, not down. Who also has that? There might be some people here who have that. Check both sides. What we're going to do, if you see this, I'm going to shove his lung toward his C7. That's it. But I'm going to feel the tender point relax when I do it.
Okay.
Now, usually I'm going to do this on a treatment table. Don't have one, so we're going to do it with him seated. So I'm just going to grab this upper lobe of the lung. I'm going to be over this tender point right here, which he does not like. Okay? Again, it's tied, literally physically tied to the brachial plexus. So I'm going to compress posterior and drive the lung superior medial. How does that feel? Surprisingly better.
Yeah.
I could have also, which I forgot to do, had him do a deep inspiration. And I would be able to see that the capacity of him to breathe into the upper lobes is diminished. This is one of the things I did on that woman case study I told you about who could not breathe into her upper lobe. Okay? It takes about 30 seconds for the inflammatory chemicals to drain out and restore function. Okay? How are we doing now?
Much less tender.
Much less tender. We'll check the superior aspect of the rib tubercle at 1. Better? Okay, now we're not going to have a direct stack on the other side. Like a suspension bridge, if you cut a cable on one side, it's going to take up tension, not at the same site, but above or below. Okay? So T1 over here means we're going to have a C7. Actually, this was C7 and T1 for this particular center point, but typically we'll have a T1 and then we'll have a T2 or C7. Or a T1 or T2 over here, T1 or T3. Or sometimes you have a T1 and a T3 balancing a really bad T2. Okay?
Mm-hmm.
So if we go over to this side, we can see there's a 2 right there. You feel that guy? Okay? So this one is the pleural dome anterior. So I'm going to do something similar here to this side, compressing the lung. We're going to go this way though. We're going to give a nice compression here and drag that lung superior and lateral. How are we doing now?
Much less tender.
Much less tender. Okay, so that's a typical quote-unquote stack that we do in fascial counterstrain. You have to balance it. Only have pain on one side, always treat both sides. Or else they'll walk out catawampists and call you later and say, now my left arm hurts. What did you do to me, Doc? Okay, good. All right, just with those two, let's see if we have an improvement. Tell me when you start to feel it now. Now we're at 90.
Look at that.
Right there, so we're 20 degrees past. Can you stand up?
Gain like 40 to 50 degrees.
Let's see what your lateral flexion looks like now. Wow, look at that. Other way. Woo! All right, now lateral flexion of your neck. That's an improvement too. We still have more work to do in your neck, but that's significantly better. What'd you say? So if you guys want to learn this in my slides tomorrow, which I'm the last speaker tomorrow as well, if you want to learn this, there are schools, like I said, Kiné Formation, that's probably how I say it in French, I'm guessing. And then there's a school in Australia as well. Ask me for my slides. I'm 100% fine with people having recordings of anything I do. In fact, we recorded this today. If you want a recording of this, please ask for it. I want all of you to learn this. I also want you to know that there are references on the slide tomorrow, which isn't on the slide today. You can find practitioners that are near you to refer to. It takes a couple of years to really learn all of this. This is just a teaser, okay? And I will come to you if you get enough patients or enough students who want to learn this, okay? My mission is to get more of me out there. So please, please, contact me with any questions.
So we know